So the next talk that we're going to talk about is the 12-lead EKG and looking for clinically significant findings. So Sharon Schaaf is an associate professor and clinical educator as an adult gerontology acute care nurse practitioner. She works at UNM in nursing, in the nursing department, and she has many, many, many years in cardiology, taught lots of courses on interpretation of EKGs. I bet you, if you asked her, she's taught workshops here teaching MPs how to read EKGs. And if that's something you're interested in for a workshop, you might want to put that in your eval. So
I have to open my presentation first. She's working on it. It's on.
So we'll wait for her to get mic'd up, and she doesn't know, but she has to answer a fun fact too. She's been in the other room all morning long teaching about different ways to do telehealth and presentation talks, doing poster presentations. So that's something that the conference committee talked about, is doing poster presentations. And if you think that would be an awesome idea, also put that in your eval. We want to encourage new grads to come and join in MPC, and some of them have to do poster presentations, and this would be a great way for them to display it, not for a grade, but for their peers to look at, and for us to learn some new things that they could potentially teach us.
Just check my displays and they haven't mirrored it earlier.
And she's also a technology guru.
All right, so you went from here. I don't know where you went from here on that.
Miss Sharon,
Yeah.
while she's getting you squared away, do you want to give us a fun fact about you?
What's a good fun fact I can share? I have no life. I was the soap booth out there, and my free time, well, in my free time, I do soaps, I do quilting, and if you missed the presentation earlier, you saw me doing epoxy tables.
Epoxy tables.
Yeah.
What do you put on your epoxy? Some people do like turquoise or things like that. What do you put in your table?
Oh, no, we're talking big tables.
Oh.
Yeah.
Dinner tables.
Well, maybe I haven't done them that size. I did a 4x4.
Coffee tables.
Yeah.
Okay.
Stuff like that.
Sweet.
So, yeah.
So you're an artist, you're a crafter.
Well, not really, but yeah.
Okay. Well, I'll let you get started.
Okay. There we go. Okay. Oh, can we move that? Well, I don't think they want that on there. Oh, go back. There you go. Now move it. Don't look at my messy desktop. I said, don't look at my messy desktop. Oh, I didn't put my phone number on here to text.
I'm going to put it in the text right now.
Okay, because then I want to keep that here. So thanks for attending this one. I was all morning in the other room. So now we're doing 12-lead EKGs, and we're doing clinically significant findings. So we had lunch together. So who here is comfortable reading 12-lead EKGs? I see like 2 hands. And I mean, that's even without my readers on. Okay, so when I first thought I was going to have a lot longer, I'm like, oh, I have to come up with all these EKGs. And then I went to my batch, I picked the cool ones. So they may be, these are all in the handout. I did add a bonus EKG at the end because it just happened after I uploaded this. Okay, so the objective for this is to correlate findings on the 12-lead EKG with their clinical significance. And I want to talk about this because let's get a 12-lead EKG. Let's read the top. Let's see what it says. Okay, I have to refer or whatever. But now in this one, I want you to take a look at the EKG, see what it means to you clinically in your patient related to their physiologic process. Sound good? I know it's after lunch and it's So let's give you a couple of good EKGs. So if anybody were to take a gander at this EKG,
Somebody trying to dial in a balloon pump.
volume, I'm not in charge of volume. Who is? My mic is on. That's the one thing I'm not in charge of for right now. Anybody? My two ACNPs in the room. Are you sure? No. Now that I said that, you're not sure anymore, right? Because you're like, that's always a good one. Oh no, the patient's doing this. Okay. No, they're not. This is actually an EKG of hyperkalemia. Okay. Hyperkalemia. Okay. This is one of the probably the most classic ones that you'll find. And I mean, I'm again in the other room. I told you I'm creepy. I go around taking pictures of people's poster presentations to, look at and go, what would I do different? What would I like? I do that with EKGs. I'm always copying all that stuff. So this one, whenever I get a good one, is really nice. So as we look at this one with a hyperkalemia, I'll review it with you. The classic sign is a sinusoidal wave type form, which is when I do this, it looks nice and flowing and okay. But when your patient's doing that, it's not. Okay. And I'm going to tell you, I think this is one I got the call from the ER doctor, ER physician, who said, hey, this is kind of VTAC, but it's kind of funky looking. That right there raised my red flag going, I wonder if it's a hyperkalemia, because you have this sinusoidal waveform. And you just notice that it keeps on going throughout all of these leads, right? It's not like upright in one, downward deflected in the other. It's all, when you look across these top leads, it kind of looks the same. Even when you go to the inferior leads, kind of the same thing, okay? Hyperkalemia. If you're in the ER, you're like, oh, let's treat it. We give them the cocktail, hopefully it improves. I mean, their potassium at this level is probably looking like 8, 9, something like that. And I'm saying some of these in a blasé manner because I see these so much, I don't think about them anymore. As exciting. VTAC, okay. So we treat hyperkalemia, da-da-da-da-da. What does it mean to you as a clinician? Panic is, all right, that we're here, we're professionals, we don't panic. It's not on the outside, the heart's going, okay. Why is somebody in a hyperkalemia state? I'm hearing mumbling. End-stage renal disease, they ate too much potassium supplement. Oh, Mrs. Dash, it's a potassium supplement, right? Or they've taken the pills, because they're on Lasix. Okay, right? Things like that. What else? I need the volume turned up. Okay, or they've just been recently started on ACE or ARB, and this is their side effect of the medication. Okay, or they've just been started on spironolactone. Okay, thinking about that. Why are they started on ACE or ARB? Blood pressure, renal protection, things like that. Why somebody started on spironolactone? Heart failure is a big one. Okay, it's part of the guideline directed medical therapy, GDMT. So good at saying that one out. So yeah, they come in with heart failure, let's put them on a little bit of spironolactone. 25, we check their lights. You should check their lights in a week. I've had them come in, their potassium's now 6 or 7. Okay, so you think they're in heart failure. What does it mean when you have, okay, my patient's in heart failure, systolic or diastolic? What other questions do you need to ask? I know I'm going down the rabbit holes. Is it systolic or diastolic? Just things to think about. Okay. Why else would they be in a hyperkalemia? And we see these in the ER all the time. What? Crush injury, yes. Trauma. Okay. CrossFitters. Yep, doing a lot of that, so they end up in like a rhabdo or something like that, and then they, you know, all that stuff. Okay, that's a good one. Acute kidney injury, right? They have an acute kidney injury. How many of you as outpatient, patient calls in, says, I'm noticing a little more edema in my legs. I've had some weight gain. You say, increase your Lasix. You 20 daily, take it 20 twice a day. Doesn't sound too bad, does it? A week later, I see them in the ER and their creatinine's 3. Their potassium's 8. Okay, so this is from the cardiology standpoint, the cautionary tale is, if you're thinking AKI, you're increasing somebody's Lasix, always think a week out, a week out. I always, even when I get the phone calls when I was on nights, hey, you know, I'm like, you can take an extra dose for 3 days. Then call the office. And I make sure, you know, you document it to whoever the provider is, things like that. So if you're going to say, yeah, I'm just going to increase their Lasix, do it just for a couple days, make sure they call back or you call them and see how they're doing. Because we'll see this in the ER a lot with acute kidney injuries. Okay. Which is one of the reasons I wanted to show this one for hyperkalemia, because I had somebody come in, they were hyperkalemic, they were doing this plus some, this intermittently with asystole. And the ER physician thought, he keeps falling off the monitor. I'm like, no, he's not coming off the monitor. He's going, there's no electricity, you know, and we took him to cath lab and it was all metabolic. Thank goodness, wasn't a STEMI. But if it was, oh, I have that one later on. Okay. Okay. It's less sinusoidal. Let's put it that way. It's a little bit more tight. Okay. This is a little too wide to be a VTAC. Okay. But if you ever see this like in your clinic and you're like, oh, yeah, consider that this is the problem and this should be referred to the ER. Well, so should VTAC. Any questions on this one? Any other questions? Yes. I've seen a lot of different presentations on this. Some people, I've had somebody, she came in, it wasn't this particular EKG. She came in because her chief complaint was leg pain. So she had peripheral vascular disease. Okay. So her foot was mottled. Okay. And then we put her on the monitor. You know, we tried to take a pulse. It was really slow. We put her on the monitor. Heart rate was like 17. Okay. She still was having to be in a little narrow complex at that time. She had tall peak T waves, so it was interesting. So what happened is we're Dopplering her. She just doesn't have enough beats to push the blood down that leg that has peripheral arterial disease. Once we fixed her potassium, her heart rate up, her foot pinked up a little bit, and she didn't have any more leg pain. We had to fix her potassium. So some people come in totally out of it and they're unresponsive. And then there's that gray zone where they come in there. Yeah, I'm just feeling weak, tired, fatigued, all of those. But then some just like, yeah, it was weird. It was just a funny leg pain. So, any other questions? How many people present weak and fatigued to the office? Okay. And I'm not trying to point out the zebras. I mean, in cardiology, this is really not a zebra, unfortunately, but just start thinking about things about looking at their med list. What medications are they on? Are they having interactions? We went over the one case yesterday that they were on a bunch, you know, just looking at all those. Has their diet changed? Are they dehydrated? That's another cause for your AKI, especially in the hot weather, right? Done. Next. Oh, another good one. Any ideas, thoughts, comments, guesses? She's saying history of heart attack, okay? And now I'm going to say, and why do you say that? And that's fine. That's why we're here. We're here to take guesses because I'm going to tell you some EKGs I'm guessing at. And I guess, and I send it to the cardiologist. I'm like, this is my guess. What do you think? So, and that's why, hey, I'm not sure, get a second opinion. That's the entire reason why. I do see a Q wave in V1 and V2. Here, I want to point out, here's V1. So I have this Q wave here, long in V2, but I don't have it in V3, V4, V5, or V6. So it could be. What else? Okay, he's looking at some ST depression laterally. I'm going to say here in V4. You have some T wave inversion, right? ST depression. And you have it here. You have it in, kind of in lead 2, not so much in lead 3 or AVF, but you have an AVL. Okay, what else? What else do we notice about this? And I'm asking you for the something you see that's in your face. Yeah, they have huge honking QRS complexes, right? I can't even find them because they all kind of like run together, right? It goes up to about there. What does it mean when you have these huge honking QRS complexes? Hypertrophy, okay? Left ventricular hypertrophy. So you'll see maybe that on top of the EKG. Why do they have a left ventricular hypertrophy? That's the next question, right? Guesses? Aortic stenosis, why? I have to ask the whys. The valve is calcified, but what happens to the heart in response to that calcified valve? Remodels, okay? You know, we all understand, you know, there's the hose, you put the hand over it so the water can't get out. All right, so something happens to that hose, okay? It gets brittle, it may bulge out at, you know, end stage. But because the heart has to pump so hard against that, it builds up and becomes hypertrophic, which we don't want that in the heart. We do when we're like kind of work on our, you know, upper body strength or leg strength or something like that, but not the heart. Okay, so you're going to have a thickened left ventricle, okay? And that's why you have this whole big electrical conduction throughout that, because there's so much voltage there, okay? So aortic stenosis is one. High blood pressure, same thing. The heart has to pump so hard, and that's, you know, why we're trying to do blood pressure control, is because the physiologic response of the heart is then becomes hypertrophy. This, for me, is an example of end organ damage for high blood pressure. I'm going to tell the outpatient people, I don't use the ophthalmoscope to look for what papillary edema there at the back. I can tell by an EKG. It's easier. I think you can bill for it too, but not much. So yeah, blood pressure. Now remember, none of these are mutually exclusive because you can have aortic stenosis with high blood pressure, right? How do you manage a patient with aortic stenosis and high blood pressure? What's your goal blood pressure? In general, for blood pressure, when they have aortic stenosis and it's severe enough, we allow for a more hypertensive patient. The rationale being is you have a fixed orifice. Only so much blood is going to get out, no matter how hard you pump, no matter what their stroke volume is, any of that. So anybody here have those patients with labile blood pressures? Where they, you start them on a med and they're like, they're high, you start them on a med and they drop. And they kind of go up. Am I the only one? Okay, I mean, you know, because I've helped some outpatient nurse practitioners with this management, is yeah, they may have some aortic stenosis component, but you're trying to get them at goal. But in this particular case, we want them a little higher, because if you do afterload reduction, right? Which drugs are afterload reducers? ACEs, ARBs, right? And lodipine, some calcium channel blockers, right? You're going to drop their pressure. And then what's going to happen? They're going to die. Yeah, it's going to be too low because they can't get that coronary perfusion. So you have to be careful on the diastolic. You want to keep it to a nice, you may end up keeping it closer to 90 versus 80 or 70. Systolics, they may run 140s to 160s. We're okay with that, because if we drop them too low, they're going to die. You want to avoid the afterload reducers. You want to make sure they have enough volume in there, because they're going to be very responsive to diuretics with their blood pressure. That's when some beta blockers may come in handy, or the ones that are not necessarily afterload reducers. Okay. What else about LVH? Tell me why, what's one reason we do sports physicals in athletes? Because they die. Sudden death. Why do they have sudden death? Is anybody here not do sports physicals, or see that population? Okay. You do them, grab a 12 lead, you see LVH. This particular EKG is actually hypertrophic obstructive cardiomyopathy. Those are the ones that drop dead. They have an LVH that's different from aortic stenosis. They have actually a physiologic derangement of the muscle cells themselves, which cause that hypertrophy. And what happens is their heart rate goes so fast that the anterior leaflet of the mitral valve hits against the septum, so blood can't get out. And if blood can't get out, then there's no coronary perfusion, and then they drop dead. So that's one other case. So when you see LVH, always start thinking about this. I hear it. Do I hear a murmur? Or I see it. Do I hear a murmur? Murmur of aortic stenosis? Does everybody remember what that sounds like? It's a systolic murmur. It's a loud, harsh murmur. It can be squeaky. It can have an component to it. It can be it's more harsh than a mitral regurgitation, which is more of a blowing kind of thing. I try and picture it as waves kind of crashing on the rocks, at the beach, crashing on it. It's a really kind of a rumbling sound like that. With aortic stenosis, it's going to be louder early on to mid physiologic process. As you start getting into later stages where they may end up with heart failure and all that, it can get softer. So you cannot determine the severity of the aortic stenosis based on level 1, 2, 3, 4, 5, or 6, grading the murmur. Okay. Later stages are going to be softer, so you got to get an echo. All right. So things to think about. And I really am hoping I'm trying to get you guys thinking in different directions. So this one is actually, and you have the T-wave abnormalities because you have an abnormal depolarization. So you have abnormal repolarization, which gives you those deep T-wave inversions. What else on LVH? So yeah, so rely on your clinical exam. See if you can also take that murmur. Okay. Any questions on this? Any other questions on this? No? Okay. Number 3. These it looks like a fairly benign EKG, doesn't it? All right, he spotted PR depression. How many here when we learned about EKGs learned about PR depression other than the ACPs? Nobody. Okay. Where do you see PR depression? Yes. I'm also seeing it in lead 1, AVL, and V5 and V6. So let me point those out to you. Hold on. Reader glass. I don't qualify for LASIK, and then I have contacts and I have to use these things too. Okay. Lateral leads. So, whoops. I hit play again. Sorry. Lateral leads V5, V6, 1, AVL, and he saw them in lead 2. Possibly they're in AVF, but the baseline is a little wandering because the patient decided to breathe during the 12-lead EKG. Kind of rude, right? So as I look at this, when you look at an EKG and you're suspecting, are they having an ST elevation, MI, whatever, and we look at the ST segment, but compare it to the PR segment versus, or the isoelectric line versus the PR segment. So you want to find out where your isoelectric line is, which is right here. Here's your ST segment, but now here's my PR. Can you see that? I know it's here. I always still have to make sure it's showing up on there. ST segment, or isoelectric line, ST segment, PR. All right, the patient breathed there in the inferior lead, so I can't do anything with those. So if you were just to glance at this, you might look at that and say, that's ST segment elevation. It's borderline. I mean, it's only a millimeter, but that counts. And it's in 2 contiguous leads. Same thing up here. And here. Not so much, a little bit in AVL. I hate it when they breathe. Okay. So you might say, hey, this is a STEMI, which we would always rather you caution on the side of, you know, the worst possible scenario. Okay. This particular one, again, also look at your patient. How's it? They come in, they're having chest pain. You do an EKG, you're like, oh, we're having a STEMI. Listen to their signs and symptoms. I get calls on this all the time. They come to the area, they're having chest pain, go there, and sometimes I think nurse practitioners might be the only ones that actually palpate. Because I said, show me where it hurts. And they'll go, right here. Point tenderness. I'm like, so then I palpate along the sternal border, and they're like, oh, right there. Already thinking costochondritis could be related to pericarditis. That's what this EKG is. That's why the PR depression is important. If you have PR depression, that can be a sign of your pericarditis versus an ST elevation MI. Okay. Now, if you look in lead AVR, you actually have PR elevation. So if you were to compare it to your isoelectric line, you actually have an elevation. You have to be careful on V1 because it all depends on whoever placed the lead to do the EKG. Sometimes they put AVR here and V1 here. AVR should really be more up on the shoulder. V1 should be a little bit lower down there. Okay. So this one is actually a pericarditis. So you're going to look, I mean, if you think it's a STEMI and they're presenting like they're diaphoretic and crushing chest pain and nausea, vomiting, all that stuff, you treat it as a STEMI. But if like, you know, I've had an upper respiratory infection, you know, a week ago or something like that, sometimes those things just settle in the chest. I had one that came in, it was a weekend. 3 times I had people come in with pericarditis. Well, let me rephrase that. One was an older lady. She came in. She was having chest pain. They thought it's just pericarditis, and then her troponins kept elevating. She was still having pain. She had risk factors. I called the cardiologist and I said, I'd take her. I'm like, I'm like, let's get the echo. The echo showed wall motion abnormalities. Okay, we took her to the lab and yeah, we had to, do something to her circumflex or something like that. Okay, it was initially thought as a pericarditis. Another one was somebody else who came in. It was a classic pericarditis presentation. It wasn't anything else. So then the third time I'm calling this cardiologist, I'm like, oh, he's gonna kill me. I'm texting him the EKG and he calls back, Sharon, this is just pericarditis. I'm like, I know that, but he dropped his pressure to 55/29. Okay. Yeah. So that's when, all right, as cardiologists, we have to do you remember how to do pulsus paradoxus assessment? Remember the last time you actually did one? It's hard. You put the blood pressure cuff on, you watch when they're inspiration, expiration, you're auscultating, you're trying to watch the manometer. All right, this is assuming that you have just not a non-invasive blood pressure machine. You have to watch the manometer thing or a little dial. So it's a lot of psychomotor skills that you have to do. One of the easy ways I do it, I don't know, maybe it's kind of like the poor man's CVP, central, Eric might get that one. So what I'll do is on the arm that the blood pressure cuff is on, I'll do like I'm palpating a blood pressure, inflate the cuff, slowly deflate it, have them take a deep breath in and out, and note if I change in intensity of the pulse. It's not perfect, but it gives you a clue, just to let you know. And that's if they're really having tamponade. So we had, and I'm telling the guy's 23 years old. That being said, you can't ever just say they're not having a STEMI because they're only 23. My youngest patient with a STEMI was 26. He just had bad genetics. But one way to help you, this took in the lab and we got all sorts of pus out from his chest, from his pericardial sac, and he felt much better after that. Go figure. So yeah, so yes, this has ST elevation. It's not necessarily STEMI. This one happens to be pericarditis, but then think about your patient's history and what does it mean when you're like, what do they look like? What are they presenting like? We see patients with post-MI come in with Dressler syndrome because they have a pericarditis and may have a little bit of an effusion. It's not uncommon. I had a heart attack a week ago. They're going to have evolving changes, but they can't have what's called Dressler syndrome. Okay. Oh, sorry, 4. Somebody said AFib, you would be correct. AFib with rapid ventricular response, okay. Which is true. It's irregular. When it goes fast enough, though, it can appear regular. But if you're in the outpatient clinic and this is what your patient doing, a heart rate of 180, you know that 911 is in their future, right? Okay. So now, okay, they're an AFib RVR, boom, get them out of my hospital, get them out of my ER, whatever. But if they're in just plain controlled AFib, what are you thinking clinically? And we had a talk on the warfarin and the DOACs yesterday. What's their CHADS VAS score? Are they on are they on anything yet? Do they have a history of it? Is this a new onset? Anything like that? Do they feel these palpitations? I have patients come in like this and like, I don't feel any palpitations. Those are the scariest ones. The ones who feel them, I'm like, thank goodness. Okay. The ones who don't feel it, we had one that came in not too long ago. He'd been in it for a month. He goes, I didn't feel him. And he now has a tachycardia induced cardiomyopathy. His EF is like 25%. Once we can get him rate controlled and doing better, we're really hoping that his EF will improve. But again, you do weights, you do the arm weights. I'm trying to work on my upper body strength. The other day I was doing push-ups. I got to 59 of them. Yeah. And then I did a face plant, I'm like, because I couldn't get to number 60. Okay. My goal was 60. But that's what happens to the heart. It gets so tired and fatigued, it just poops out. And so then we see him like this. Okay. So that's when you have to go, how long have you been in it? Have you felt it? We don't know. What is their CHA2DS2-VASc score? What's their HAS-BLED score? Which anticoagulant am I going to put them on? You know, based on what we've got going on, look at their history. What triggered this? Sometimes it's purely electrical, but not usually. Usually there's a trigger for it. We see it a lot in patients who are septic, febrile. Okay. Pulmonary disease, COPD. What was the other part? Marathon runners sometimes can. Hyperthyroid. I'm sorry, I get my little palpitations every once in a while. I have to do this. Yeah. COVID patients. Well, they kind of like just septic, you know, everything goes wrong with them. Okay. Thinking about along those lines. Now imagine what else physiologically is going on. These people usually have some atrial enlargement. Okay. So we'll do an echo. If they have a normal size atrium, we know it's a fairly recent AFib. If they have like, hey, my LA's, you know, 6 centimeters in diameter, we're like, they've had it a while. They have these huge things. You know, if they have mitral regurg going along with this, so you're going to listen, phone, you're going to listen with your stethoscope for a mitral regurg, right? That gives you clues on, is this been going on for a while or not? Now it's different, it's difficult to differentiate between a functional systolic murmur, sometimes along with a pathologic one. Echoes really help. Especially at 180. You can, and it takes practice. I really listen at it, but yeah, after 20 years, I've gotten pretty decent at it. But those are things, you know, now patient clinic, kind of think about what could be going on with this person, okay? Because their atria is so large, it's pulling on the valves of the mitral valve. What meds should they be on? Yeah, looking at those. Last one, I think I have a bonus one in case you want to look. We'll go over this one real quick though. This one's very subtle. And I don't know if I'm going to pick on the ACNPs in the group. No. I'm going to pick on Jennifer Schneider in the background. What? 6 minutes. Okay, good. This one has a QT prolongation. And I'm only asking Jennifer because she's psych mental health and she talks a lot about those psych meds. So this is a patient who has a QT prolongation. It looks fairly benign. This is probably the one time that I end up looking at the top of the EKG because I want to see what that QT, the QTC, which is a QT corrected for heart rate. What is that number? Now, in my case, I remember the number 500. Okay, if you're over 500, it's really long. I think upper limit for women is like 480, 20 milliseconds. I'll cut them a little slack. We're on certain medication. What medications are they on? Are they on some that they, you know, are on for keeping them out of AFib, sotalol, dofetilide, those kind of medications, but psych medications, right? Which other ones? What antibiotics? Ondansetron. Methadone. Antibiotics, fluoroquinolones. Notorious for that. I mean, there's a lot of them out there. You Google QT prolonging medications, and there's a huge list of them. So, you know your patient has a borderline one, be very cautious on that one. Now, some people have genetic causes of long QT. It's long QT syndrome, LQTS. So they're just genetically prone to it. And what happens when they have long QT is what, Jennifer? You know, we're all worried about it. They go into torsades. They have an R19 and then they don't look very good. They're on the floor. Okay, how do you correct this? What's a way to correct this? Magnesium. Magnesium's a good one. And don't have to worry about being subtle about it. There's times I've had to give like 4, 5, 6 grams IV. Okay, to get them to shorten up, to get them to stop having arrhythmias. Okay, this is the last one. This is the bonus one. And there's a clue on the top left to tell you what it is. And the Zoll guys were here I shouldn't say the Zoll team was here the other day, and they talked about ventricular tachycardia. I got the call on this that was the last time I worked. I'm there on the unit. I'm on one floor. I hear the overhead react to room, whatever. And I'm like, it's not my patient. No, wait, no. And I'm like, oh, it's my patient. I better go. So I get there, and this is what was showing up on the monitor. He'd been having these episodes, syncopal episodes, kind of feeling lightheaded. Yeah, they present with syncope. What's one of the first things you should kind of think about? That or heart block. Because they're brief episodes. He was just having these brief episodes. Nothing had been caught on tape until this big long one. He was feeling a little fuzzy. He didn't see the big light. You know, I always describe it as a big light at the end of the tunnel. He was just like, I just feel a little funny. Wife said he was a little pale, but he wasn't like diaphoretic and all that stuff. But he'd been doing this. So then our question, as far as clinically, I'm thinking, why is he doing this? Does he have coronary heart disease? Well, we don't know. This was a Sunday. Monday, he's getting a heart cath, determine if it's ischemic or not. And I know this because I remember talking with them afterwards. He had a clean cath, which is good. I mean, 64, I'm like, hey, that's good. Clean cath, okay. With the ultrasound of his heart, his EF was 25%, 20 to 25%. Yeah. I don't know the story after that, but then we have to start thinking about the reasons why he has a non-ischemic cardiomyopathy. Genetics is one. We have those patients. Drug-induced, all the meth users, cocaine users always get, this guy didn't. He was kind of clean. Was it just really a tachy-induced cardiomyopathy? They were doing that workup, and I don't know what the answer was. But that's something to always consider when your patient's, some dizziness and all that. Make sure you're checking for arrhythmias. This guy, he had a clean cath, he did this, he gets a device, he gets an ICD. To kind of save his life in case it happens again. I mean, he was lucky this was in the hospital. He spontaneously converted out of it. Any questions? Any more questions? Hold on, microphones. I have to talk.
For those of you who don't do a lot of EKG reading, the way, and then obviously this is not set up like a traditional EKG with the boxes in the right places.
No,
but,
this is from the telemonitor room.
right. But AVR, because the AVR is the high right sided lead, if you have upright,
That's AVR.
AVR is in the middle there. If you have upright complexes in AVR, you know that it is a ventricular rhythm. That's one way to differentiate between.
I would say 99%, because some people are weird and there's always that point where, or 1% of the population. But yeah, if you're not sure, you only have one lead to check, put it in the AVR position. If it's upright, most likely it's ventricular tachycardia. Okay. If they have a history of MI and they're in a tachycardic rhythm, it's wide complex, you're not quite sure. Always, they have like a 95% of it being ventricular tachycardia. So there's an algorithm that goes down and says, yep, they have this, they have this, they have that. What other questions? I'm here for you.
All right.
More than you ever want to know about EKGs. Now you're terrified about looking at one going, oh no.
Okay. All right, Miss Sharon, thank you so much. I honestly just want to vomit because I went to acute care school and I'm like, oh, I didn't learn nothing. Not a thing. All right, guys. So we're on break from 3 till 3:30, and then we'll come back and learn how to read, hopefully more successfully, chest x-rays. If you need EKG practice.
I'm not doing chest x-rays.